friends, this is Riddhi Joshi and today I am going to talk about elbow joint differential diagnosis. Let's learn on the basis of pain location. If it is located anteriorly, that means patient has a problem with Pronator teres syndrome, especially in throwers, elbow dislocation, bicipital tendinitis. If it is located posteriorly, that means olecranon bursitis, triceps tendinitis. If located medially, that means medial epicondylitis, ulnar collateral ligament sprain. If it is laterally, then posterior interosseous nerve fracture of the radial head, Penner's disease, or lateral epicondylitis. Let's learn differential diagnosis of tennis elbow versus golfer's elbow. On the basis of age, we are first going to learn for lateral epicondylitis, that is also known as tennis elbow. Age is 35 to 55 years. If it is in acute case, so insidious onset. If it is chronic, then gradual onset. Mechanism of injury: overuse of extensor carpi radialis brevis muscle, racket grip. Means if they are playing tennis, so they use racket. So if grip is not proper, that may lead to the tennis elbow. Heavy racket sports like squash, tennis, badminton. Occupational activities like sewing, knitting, carpentry, bricklaying, etc. leads to a tennis elbow. Let's learn sign and symptoms. In lateral epicondylitis, patient have morning stiffness, acute pain that is associated. If it is acute, so that will be associated with bruising on occasion. If it is chronic, that may be due to occupational neuralgia and weakness of the grip is there. Then patient have location of the symptoms in lateral epicondyle or proximal forearm. Swelling is present at lateral aspect of the elbow. Aggravating factors like repetitive activities which involve extension. Medication can relieve the pain and rest can also relieve the pain. Rest, especially with the splinting, that relieve the pain. If patient is having active range of motion problem, so patient may have possible pain over the wrist flexion and with elbow extension. If passive range of motion is painful, then pain on wrist flexion with forearm pronated and elbow extended position. Let's learn resisted isometric for lateral epicondylitis test. So if we are doing resisted isometric testing, pain on resisted wrist extension and radial deviation. Especially patient is having elbow extension, so pain in finger extension. Special test: Mills test, Cosen's test, and tender on extensor carpi radialis longus and brevis muscle. MRI can confirm the diagnosis and special test also can confirm the diagnosis, but diagnostic feature will be MRI. Now we are going to learn medial epicondylitis, that is also known as golfer's elbow. Gradual onset is there. Age is 35 to 55 years. Mechanism of injury: repetitive force on elbow, flexor carpi radialis and pronator teres plus palmaris longus are affected in golfer's elbow. If we check the sign and symptoms, pain with resisted wrist flexion or passive wrist extension plus supination and radial deviation, that will cause the pain. Numbness in fourth and fifth finger is noted in medial epicondylitis. Pain location: pain is located on the anteromedial aspect of the elbow. Swelling present on the anteromedial aspect of elbow. Repetitive wrist flexor activity that cause aggravating of factor of the pain. Medication and rest or splinting can relieve the symptoms. And if patient is doing active range of motion, so pain in wrist extension, and if doing passive range of motion, pain in wrist extension and supination. In medial epicondylitis, if they are doing resisted isometric testing, so pain in pronation and wrist flexion, difficulty in lifting the palm down. Special test: passive supination of the forearm and extension of wrist and elbow cause the positive test. Tender on palpation, so anteromedial aspect of the elbow is tender and MRI can confirm the diagnosis of medial epicondylitis. Now we are going to learn ulnar or medial collateral ligament sprain. Age of onset is 25 to 45 years. Mechanism of injury: excessive valgus force on medial compartment of the elbow can cause the ulnar collateral ligament sprain, especially in baseball pitchers and javelin throwers. They have the medial collateral ligament sprain. Sign and symptoms like overhead throwing that cause the pain and soreness at the elbow. Patient may feel numb and tinglingness at the elbow. Pain located on the medial aspect of the elbow. Valgus stress test or throwing and pitching can aggravate the pain, and medication and rest relieve the pain. Let's see swelling location. If patient is having ulnar collateral ligament sprain, it is located over the medial side and ecchymosis of the elbow we can notice. And range of motion, if patient is doing active range of motion testing, so for that pain will be in full extension. And passive range of motion, passive extension of the elbow and valgus stress test can increase the pain. Resisted isometric is not remarkable, and tender on palpation, especially on the medial aspect of the elbow, means ulnar collateral ligament side. And the special test like valgus stress test is positive for UCL sprain, and diagnosis is confirmed with the help of MRI. Let's learn triceps tendinitis, that is differentially diagnosed with the help of olecranon bursitis, because their pain location is posteriorly, so we have to rule out that is it tendinitis or bursitis. So age of onset is 20 to 50 in both, but in mechanism of injury there will be hammering activities, boxing, and the overuse of the elbow and arm that cause them triceps tendinitis. Pain is worsened with the movement. Swelling is present near the point of elbow. Extension activities can aggravate the symptoms. Active range of motion and passive range of motion testing. In active range of motion testing, extension of the elbow is affected, and passive range of motion like shoulder and elbow flexion cause the pain. And resisted isometric, if we are doing elbow extension, so that cause pain. And special test is not specified, but if with the help of the x-ray we can diagnose and indicate the rule out of olecranon epiphysitis. Especially patient is having pain on and tenderness on posterior aspect of elbow that cause the pain. Prognosis is good. Let's differentiate with the olecranon bursitis. If patient is having olecranon bursitis, that is also known as student elbow, draftsman's elbow, or Minard's elbow. If patient is having acute onset, so acute case is there, so sudden onset is there due to infection or trauma. Generally this olecranon bursitis is gradual and slow onset. This is caused due to repetitive strain injury, trauma, inflammation of the bursa that cause olecranon bursitis. Sign and symptoms: decrease elbow extension, because that bursa is located posteriorly, so elbow extension is limited due to bursitis. Swelling is present in the posterior elbow aspect. Characteristic of swelling is warm and thick. Contact with the posterior elbow, like if we are students, so we study with elbow resting on the table, so that cause pain on posterior side of the elbow. Let's see active and passive range of motion testing. If patient is doing extreme elbow flexion cause pain, with passive full flexion cause pain. And resisted isometric is strong and pain free, because here muscle is not affected, and the special test is not specified. Posterior aspect of that elbow is very tender. MRI can confirm the diagnosis. Lab test like aspiration test, serum or blood test we can do for this patient. Prognosis is favorable. Aspiration may needed for fluid. Let's learn biceps tendinitis. So age is 20 to 50 year. Mechanism of injury: repetitive hyperextension of elbow and repetitive pronation. Sign and symptoms: aggravated by elbow extension, and swelling is not remarkable. Range of motion: active range of motion of elbow that flexion cause pain, pain in passive elbow extension. And resisted isometric, like if patient is doing elbow flexion and supination, that cause pain. Special test: speed test. Tenderness specifically available on distal biceps area, biceps insertion and muscular tendinous portion of the biceps. Diagnosis: special test, the speed test can diagnose bicipital tendinitis. Let's see cubital tunnel syndrome. syndrome, that is also known as ulnar neuritis. Mechanism of injury, repetitive stress and trauma. Sign and symptoms like weak ulnar deviation of and fourth and fifth finger flexion is affected, pain with elbow flexion, and paresthesia in forearm and fifth finger. Tenderness is present over the course of ulnar nerve. Muscular weakness is present, weakness and atrophy of ulnar innervated intrinsic muscle of hand, and possible weakness of flexor digitorum profundus muscle. Sensation abnormal over the ulnar aspect of the hand. Special test, Tinel sign is positive. Diagnosis with the help of special test and posterior or lateral plane film can confirm the diagnosis, and differential diagnosis with the thoracic outlet syndrome. Let's learn radial head subluxation or nursemaid elbow, that is also known as pulled elbow, because parents or nurse that is holding the child elbow and the radial head is subluxated from here. So age is common in 2 to 3 years. Mechanism of injury that results if parents or nurse pick up the child cause longitudinal traction on extended elbow that results in slip from annular ligament over the head of radius. Sign and symptoms, typically kids keep the arm at side, hand pronation and palms down. Tenderness is present, means the child will guard the elbow. Aggravating factor, displacement of radial head distally aggravates the pain. Relieving factor, relaxation, means if we relocate the subluxation, so subluxation reduction, that will relieve the pain. So that time we have to keep the thumb in cubital fossa that work as a fulcrum and flex and supinate the forearm. Tenderness is present over the radial head. X-ray is necessary if a fracture is suspected. Let's learn osteochondritis dissecans for adolescents. Age onset is 12 to 15 years. For Penner's disease, child is 10 years or younger. Mechanism of injury for osteochondral bone dissecans. So in that bone is detached from articular surface and from a loose body in a joint. So that will cause the osteochondritis dissecans. In Penner's disease, localized avascular necrosis of capitulum that leads to loss of subchondral bone. Repetitive force between radial head and humerus and the capitulum that cause Penner's disease. Sign and symptoms, patient is having diffuse pain on the lateral aspect of elbow. The extension is decreased, catch and locking of the elbow is there. Pain in upper extremity while weight bearing activities like lifting something, or if they are doing elbow extension exercises, so that cause them pain. Crepitus is present in supination and pronation. MRI, X-ray, and they can help us for diagnosis to identify loose body and flattening of humerus capitulum. Let's learn some fractures in humerus. So if patient is having supracondylar fracture of humerus, that is very common in children. Mechanism of injury, either flexion type or extension type. If patient is doing flexion, so it is going anteriorly. If it is doing extension, distal aspect, that will move posteriorly. So mechanism of injury, hyperextension of the elbow. If patient is having flexion type of injury, these are the proximal segments that pierce the anterior periosteum. Here the brachial muscle is there on anterior aspect that will pierce the anterior muscle, median nerve and the brachial artery. And if it is extension type of injury, so here the triceps muscle is there and radial nerve is there, so that will also pierce the triceps muscle and the radial artery if it is extension type of the injury. Sign and symptoms, that is remarkable swelling above the elbow and ecchymosis is present. Patient is guarding their hand. There may be complication like if patient is very young, so malunion is very common for that patient, and Walkman's ischemic contracture is very common in young children also. If typically that involves radial nerve, if extension injury is there, loss of motion is also there as a complication in humerus fracture, and myositis, ossification and chronic regional pain syndrome is also common as a complication of supracondylar humerus fracture. Let's see olecranon fracture. If patient patient is having olecranon fracture, mechanism of injury, fall on outstretched hand, and if patient is having passive elbow flexion and combined triceps contracture that lead to the avulsion fracture of olecranon. This is avulsion fracture of olecranon, and the triceps muscle is pulling that up, that cause avulsion. And sign and symptoms like active avulsion involves the triceps, and active elbow extension is lost in this patient. If we do palpation, so gap and pain is present. Swelling is also present at the fracture site, and large hematoma that may develop being diffuse ecchymosis for this patient. Let's learn lateral epicondyle fracture. Lateral epicondyle fracture, that is very common in 6 to 10 years of the kids, and they also mechanism of injury fall on elbow. Sign and symptoms like pain and swelling is present on the lateral epicondyle, and patient is not able to move the elbow joint when they are following the injury. And X-ray can confirm the diagnosis. Complication like non-union cubital valgus deformity is very common in lateral epicondyle fracture. Excessive bone formation, ectopic bone formation that limits the patient motion. Avascular necrosis is very common for lateral epicondyle fracture. Dislocation of elbow, that may be posterior, anterior, or complete dislocation. The anterior dislocation is very less common in anyone, so that may be 1 or 2%, but the posterior dislocation is very common, posterolateral dislocation due to hyperextension injury of the elbow or fall on outstretched hand. That causes avulsar fraction of medial epicondyle, and if it is complete dislocation, so ulnar collateral ligament will rupture, severe pain and rapid swelling is there, and X-ray can confirm the diagnosis. Let's learn pathological bone formation. There are different forms used for pathological bone formation like heterotropic ossification, myositis ossificans, periarticular calcification, and ectopic ossification. Let's learn individually. So what is heterotropic ossification? That means mature lamellar bone in non-osseous tissues. Myositis ossification means heterotropic ossification that forms in inflammatory muscle, that known as myositis ossificans. And periarticular calcification means calcium pyrophosphates within the soft tissues such as collagen ligaments or joint capsules. Ectopic ossification onset is heterotropic ossification, and myositis ossification are common in elbow that begins after 2 weeks of trauma. Sign and symptoms, for example, a patient may have result in localized tissue swelling, tenderness, hyperemia, and pain. Elbow stiffness may develop within 1 and 4 months after initial phase of motion recovery after injury. Means if patient is having an injury and initial phase is there, so in elbow stiffness is developed in 1 to 4 months. Limited active and passive elbow flexion and extension are the characteristic of ectopic ossification formation about the elbow. And ulnar palsy is there, registered isometric, weak and painful elbow flexion and extension. Chief complaint, patient have pain, stiffness, instability, sensory loss, weakness or locking, especially pain located anteriorly and middle third of the arm. The ectopic ossification is diagnosed as early as 2 weeks after the injury, and joint incongruity, osteophyte formation, malunion is apparent. Mobilization after an elbow injury is oftenly delayed. Exercise. Let's learn nerve entrapment. If median nerve is involved, age is common in 20 to 40 years. Mechanism of injury is overuse injury. Pain located on the anterior forearm and lateral 3.5 fingers. Atrophy is present in chronic case, especially anterior forearm musculature. Aggravating factor, full extension and pronation of forearm, range of motion problem or limitation. Patient have pain in forearm pronation in active range of motion, and passive range of motion is full and pain free. If we check the resisted isometric test, so for that, weakness on pronation, wrist flexion and thumb opposition. Spatial test, like patient is not able to make OK sign from his or her index finger and the thumb, so that indicates benediction sign. that is anterior interosseous nerve syndrome. Tenderness is present over the pronator teres muscle 4 cm distal to the cubital crease. Let's learn radial nerve. So if we check the radial nerve entrapment, age may vary, but mechanism of injury is overhead throwing, trauma, pain located on the lateral aspect of your forearm, and atrophy is not remarkable. Aggravating factors may vary, range of motion is not remarkable, and resisted isometric testing, pain with resisted supination, extension of a middle finger. And tenderness is present over the radial tunnel. If we check for the ulnar nerve, there will be age 20 to 40 years and overuse or trauma. Spatially, mechanism of injury on the cubital tunnel and hypertrophy of flexor carpi ulnaris plus recurrent subluxation and dislocation. Pain is located on the medial side of forearm and the medial side of the hand and 1.5 of the fingers. Atrophy is present in chronic case, and aggravating factors are wrist and elbow extension. Range of motion limitation, patient is not able to close the hand, and passive range of motion is full and pain free. If we check the resisted isometrics, weakness in grip, notice that, and Tinel sign is positive as a spatial test, Wettenberg's test, and format sign is positive. In that, tenderness is present on the anteromedial aspects of your elbow. Let's see medial nerve supply C6, C7, C8 and T1. Muscle are flexor carpi radialis, pronator teres, flexor digitorum superficialis, flexor pollicis longus, pronator quadratus, and lateral to lumbrical and thinner eminence. If patient is having median nerve injury, functional deficits noted like wrist, weakness of the wrist flexor, pronators, radial deviation, thumb flexors, abductors, and weak grip we can notice, and pinch is affected. In this diagram, we can notice the affected area for median nerve injury. Like first, your thumb, index finger, middle finger, and half of the ring finger is affected. And deformity, thumb deformity we can notice for this patient. If radial nerve injury is there, so extensor carpi radialis longus, extensor carpi radialis brevis, extensor carpi ulnaris, anconis brachioradialis, extensor digitorum, abductor pollicis longus, extensor indicis, extensor digiti minimi. These are the sensory distribution over the radial nerve. You guys can notice that the lateral aspect of your hand is there, and your thumb, and posterior aspect of your thumb and index plus middle finger is there. If patient is having weakness, the functional deficits, so weakness of wrist extensors, supinators are affected, finger flexor, thumb abductors, and weakness of grip we can notice. The common deformity is there in radial nerve injury is wrist drop. For ulnar nerve injury, ring finger and the little finger is affected. So flexor carpi ulnaris, hypothenor eminence, and adductor pollicis longus, medial to lumbrical, and interossei are affected. In this, we can notice that weakness of wrist grip and wrist flexors and ulnar deviation, adductor, weak finger, fifth finger flexor is there. Benediction deformity we can notice for this patient, like index finger, middle finger, and the thumb. Their metacarpophalangeal joint is in hyperextension, and the flexion of ring and little finger is there. Let's see pronator teres syndrome. Etiology, like supracondylar fracture of the humerus, forearm gunshot injury that is affected in the pronator teres syndrome, and onset is insidious. Pain is noted on the anterior aspect of the elbow on radial side of the palm. Palmar aspect first, second, and third, and half of the palmar aspect means first thumb, second index finger, third ring finger, and half of the fourth digit means your ring finger is affected. Heaviness in the forearm is noted. Weakness of flexor pollicis brevis and abductor pollicis brevis is noted. Sensory deficit over the thinner eminence. Special test. Apply pressure over the pronator teres 4 cm distal to the cubital crease. with simultaneous resistance applied against pronation, elbow flexion and wrist flexion. And for the special test, resisted supination and resistance of long fingers, we can use that. And we can differentially diagnose this with the carpal tunnel syndrome. In that, weakness of the thumb abductors and opponent's pollicis is affected. First and second lumbrical is affected. However, in pronator teres, only first, second, third, and fourth digit is affected. Let's learn anterior interosseous nerve syndrome. Muscles supplied by anterior interosseous nerve are flexor profundus, flexor pollicis longus, and pronator quadratus. Sign and symptoms: forearm pain, motor loss on flexor pollicis longus, pronator quadratus, and lateral half of flexor digitorum profundus. Patient is unable to perform OK sign with index and thumb. There won't be any sensory changes. Test for anterior interosseous now, we can notice the pain and weakness that is provoked by resisted flexion of interphalangeal joint of your thumb with distal interphalangeal joint and index finger. Let's learn posterior interosseous nerve syndrome. Supinator, extensor digitorum communis, extensor digiti minimi, extensor carpi ulnaris, extensor pollicis longus brevis, and indicis plus abductor pollicis longus are supplied by posterior interosseous nerve. Site for compression, like the fibrous band that connects the brachialis and to brachioradialis, their site is very common for PIN compression. Medial proximal portion of the ECRB, extensor carpi radialis brevis tendon, especially between the proximal and distal edge of the supinator and arcade of the fourchette, is mostly affected. Sign and symptoms: the posterior interosseous nerve syndrome is purely motor syndrome, so no sensory changes. Lateral aspect of the elbow pain is there, and that is radiate to distal forearm. Patient is not able to extend the MCP joints of the thumb, index, long and ring finger, and small fingers. Loss of thumb interphalangeal joint extension and radial deviation, and abduction of the thumb. Aggravating factors: repetitive pronation supination, specifically resisted supination, is more aggravate the pain. Tenderness is present on the 3 to 4 cm distal to the lateral epicondyle, where radial nerve crosses the radial head and penetrates the supinator.
Thanks for watching, and for future videos don't forget to subscribe. If you have any doubts related to topics in physical therapy exams, please let me know in my comment section so I can make a series of the videos on that. Till that time, stay positive. Bye bye.